Yes, madam.
Yeah,
Yes,
can you start
madam.
at least 9:05 in 1 minute's time, right? We cannot waste our time.
Good evening, dear Madam, Dr. Lalanta Senaratna, Consultant Family Physician at Base Hospital, Home Government, dear seniors and my dear colleagues. Today's session will be a very interesting topic for all of you, which will be conducted by Dr. Mohammad Imran, Registrar in Family Medicine. Dr. Imran has graduated from Eastern Faculty of Medicine, Eastern University, and he is a DFM holder, currently MD trainee at BH Kiribati. Over to you, Dr. Imran, to reveal us about the hidden curve.
Thank you, Dan, for your kind introduction. Good evening, Madam Dr. Saranda Senaratna and my colleagues. Today I'm going to discuss about the topic on the hidden curve. So this is the case of a 14-year-old girl accompanied by her mother, presented with a 2-month history of back pain. The pain was localized to the lumbar region, started with gradual onset without any specific traumatic event or injury preceding it. The pain was described as a constant dull aching pain. The pain did not radiate to any other area. The pain worsened with specific activities such as prolonged sitting, bending, and physical activities. However, she denied pain at rest. The pain severity was mild to moderate, allowing her to continue with daily tasks. The pain was not worsening progressively, but she experienced occasional flare-ups. The pain did not worsen at night or disturb her sleep. The associated features: patient denied any numbness, tingling, or weakness in the lower extremities. There were no other neurological signs such as changes in sensation or bowel bladder function. There was no gait disturbance, no fever, weight loss, or malaise. And also there was no morning stiffness, eye symptoms such as red eye or itching, skin rash, altered bowel habit. There is no cough, shortness of breath, abdominal pain, pelvic pain, dysuria, nausea, or vomiting. As she was an adolescent girl, I proceeded with the heads assessment. While asking about home, she is living with the parents. She described herself as a generally happy and supported by her friends and family. Her education-wise, she attends government school, currently in grade 10. She is performing well in studies, but struggle to manage her time effectively when it comes to assignment and preparing for exam. On activities, she does not engage in sports or exercise, but enjoys playing indoor activities with friends. She spends about 1 to 3 hours daily on screens, occasionally attends community events with her family. On drugs, she denied using smoking, alcohol, or drugs, but aware of the risk. She eats 3 meals a day, although often skipped breakfast. She denies any sexual activity. She reports occasional feeling of stress related to school, but denies any persistent sadness, hopelessness, or thought of self-harm. She feels safe at home and school, denies experiences bullying or physical harm. Past medical history: there was no previous episode of neck or back pain or arthritis, no history of malignancy, no history of sickle cell disease, no significant past surgical history. On menstrual history, she attained menarche at 13 years. It's regular and LRB was 2 weeks back. There was no history of allergy. Family history: no family history of arthritis or tuberculosis. So while revealing ideas, concern, and expectation, the pain may be due to heavy school backpacks, but the persistence of symptoms raises concern about potential serious underlying conditions. The family seeks reassurance and want to rule out any serious illness. there are no significant limitation in her day-to-day activities.
Oh.
So according to this history, I would like to ask what are the possible differential diagnoses? So this 14-year-old girl with the 2-month history of back pain, which was associated with movement, and there was no other significant red flag features. So then what could be the differential diagnosis of this patient?
Year 3 registrars, year 4 registrars, please answer the questions.
It may be a mechanical back pain.
Yes.
And scoliosis also possible.
Yes. True. Any other possibilities? So according to the history, now we stop with the history. So the probability of diagnosis has already mechanical pain. So all the differential of the mechanical pain should be included in differentials. It could be a musculoligamental strains or spasms, because muscle strain is very common at this age, but usually it's acute pain. Although this patient had a 2-month history of pain, but it can be persistent. And pain during and after activity, in pain with twisting or lifting, so it's correlated with the history. But there was muscle tenderness without radiation. We have to do it with the examination. So other probable diagnosis, we should always think about spondylolysis or spondylolisthesis, which are also possible according to the history. So spondylolysis is actually a unilateral fracture of the pars interarticularis. So this is not actually, it's not a spondylosis, which we are discussing during the elderly patient due to degenerative changes of the spine. This is spondylolysis. So fracture of the pars interarticularis. So you can appreciate by this X-ray as well. So if it is not treated, it can proceed into the spondylolisthesis. So these patients present with the pain, but which will radiate to the buttocks and posterior thighs, and pain worse with extension or improve with rest. And examination, we can find about the hamstring tightness, positive SLRT, and limited forward bending. So according to the history, there is a possibility of spondylolysis. Another important differential in this age, the spinal deformities. It can be kyphosis or adolescent idiopathic scoliosis, or either it can be some congenital deformities. If you think about the kyphosis, the Schumann or juvenile kyphosis is one of the important differential during this adolescent group. It is actually osteochondrosis, abnormality in the vertebral epiphyseal growth plate. So due to this abnormal growth plate, there is a wedging of the spinal vertebral wedging occurs. There is a criteria. If there is an adjacent 3 vertebra wedged more than 5 degrees, we can be diagnosed as a juvenile kyphosis. So they have typically the thoracic pain. Usually it's a thoracic pain, and pain can worsen at the end of the day and is relieved with the rest. And the examination, we could find the thoracic tenderness, thoracic kyphosis we can find, and there will be a hamstring tightness. So in this patient, the history correlate, although it's a lumbar pain, it could be a juvenile hypothesis, but because it really with the rest and there is no history of trauma, but we have to find out with the proceeding examination. So these are the mechanical causes. Another very common cause of the pain would be non-specific back pain. So non-specific back pain, actually there was no warning signs, and there should be a risk factors. Either it could be sports participation, soft mattress, some psychological causes, depression, anxiety, or some comorbid medical disorders. Another controversial thing about the heavy school backpacks. Actually, there are observational studies shows school backpacks can cause non-specific musculoskeletal pain, but the systemic review failed to find those correlation. But American Academy of Pediatrics, it advises backpack should be weight not more than 10 to 20% of the child's body weight. Which means the backpack school bag should be less than 20%. So there is some correlations. So this patient also, although we couldn't find major risk factors, as the absence of warning signs, it could be a non-specific muscle pain. But these are the probable causes, but we can't miss the serious disorders. Those are mainly the neoplasia, severe infection, transverse myelitis, or referred pain. So neoplastic pain, actually that neoplasia is not uncommon, mainly the osteoid osteoma. It's a benign tumor, benign bone forming tumor. It is common. It's very classical feature. It's a nocturnal pain relieved with anesthesia. Non-malignant tumor. So this patient also, she doesn't have nocturnal pain, but we can think about osteoid. Another malignant tumors that may be spine or spinal cord. Tumor of the spine could be primary, like even sarcoma, or secondary due to leukemia, lymphoma, or metastatic disease. They will present with the nocturnal pain, constant pain with the systemic symptoms such as fever, weight loss, loss of appetite, like that. Spinal cord tumors like neuroblastoma, neurofibroma, they also present with the nocturnal pain with the abnormal neurological finding. So in this case, this patient doesn't have the nocturnal pain, no neurological symptom, systemic symptom, we can think these are least likely diagnoses. Then severe infection, that's also in this age we should not miss that. Osteomyelitis, discitis, epidural abscess. So they will present with the fever, severe pain, constant pain, nocturnal pain. All these features could be due to any severe causes. Another important differential is the transverse myelitis. This is a transverse myelitis. Actually, there will be association. The systemic autoimmune disorders, SLE, ankylosing spondylitis, and also they will be having abnormal neurological finding. Either it could be motor, sensory, or autonomy. So another important difference is the referred pain. Referred pain, it could be from chest to abdomen or pelvis. Pneumonia, they can present with the back pain, mainly the thoracic pain, or it could be abdominal, appendicitis or cholecystitis, pancreatitis, or renal stones, pelvic inflammatory disease. Those any kind of pain may present with the abdominal back pain. So we always should consider those things. As this patient doesn't have any other features of the referred pain. Actually, as a cough or abdominal pain, pelvic pain, vomiting, nausea. So it's like a safely we can think about it's not due to any referred pain. What are the pitfalls? These are often missed diagnosed differentials. One is the very important difference is the inflammatory arthritis. Inflammatory spondyloarthropathies, either could be ankylosing spondylitis, juvenile idiopathic arthritis, or reactive arthritis. So they will be having back pain, chronic back pain with the other features, morning stiffness will be there, and sometimes rashes or enthesitis like Achilles tendinitis features, and eye symptoms such as red eye or eye pain, those things. And another important difference is the fibromyalgia. It is the chronic widespread pain syndrome. It's a chronic pain. The features is there will be a discordance between symptoms and findings. And also they'll be having frequent school absences. So and also they won't have the single back pain. They might be having the back pain in other joints or other areas. So this patient doesn't have those features. Another very important pitfall is the tuberculosis. TB, the pot disease, they can present with the chronic back pain, and also some systemic symptoms might be there. We should not forget about the important masquerades, mainly the depression. So this age group, this present adolescent group, that they are biopsychosocial, everything is different from the adult. So there is a more possibility of depression. So we always, that's what that head assessment, which will reveal a lot of their social issues, risk factors. We can think about that. This child doesn't have those features. She's living happy life, and there is no significant features of the depression or psychosocial issues. And another thing is the patient trying to tell me something. It is a hidden agenda. So we always, these things we can get from the good communication skills and talking with the patients in the mainly that assessment throughout the consultation. So these are the possible differential in my case. So we'll proceed with the examination. The examination, the general examination, febrile, not pale. There was no lymphadenopathy. There was no skin rash. Spinal examination, inspection, there was a lateral curvature on the spine. There was no kyphosis, no midline skin lesion. On palpation, there was tenderness on paraspinal region. Range of movement, normal range of movement in all the flexion and extension. Adam test, which was positive. Weber test was negative. Stokes standing test negative. Modified Schauber's test negative. There was no quadriceps tightness or hamstring tightness. Neurology examination, normal sensory motor, normal reflexes, gait was normal, SLRT was negative. Focused respiratory and abdominal examinations were normal. So the summary of this case, a 14-year-old girl presented with lumbar back pain lasting 2 months, described as aching and mild to moderate in severity, aggravated by movement. Examination revealed spinal asymmetry with lateral curvature and paraspinal muscle tenderness. There were no other red flag features. Now, what could be our differential diagnosis? So I would like to ask from our colleagues.
This should be a discussion, right? Others, of course, please contribute. Otherwise, no point of like having this kind of presentations. It should be a brainstorm as well.
So we had long list of the differentials, the probable diagnosis as a mechanical pain, and we thought about the serious disorders, neoplastic infective causes, and we talk about the pitfalls, which are arthritis, inflammatory arthritis, or tuberculosis, or some myalgias, fibromyalgia, and we talk about masquerades, depression, and the hidden agenda. within the differential. So according to the examination, we could find only the spinal asymmetry and lateral curvature and paraspinal muscle tenderness. Then now what could be the most probable diagnosis?
It can be kyphosis or scoliosis, one out of that, because there was a spinal asymmetry you have found, and spinal.
Yeah.
Since there's lateral curvature, it should be
Scoliosis.
Yeah, that's true.
Lateral curvature may be due to the paraspinal muscle spasm.
Yeah. So as you all mentioned, so those are the differentials. It could be in the age group, it could be a idiopathic scoliosis, adolescent idiopathic scoliosis, or muscular ligament strains or spasms, which also cause the spinal asymmetry due to the pain and spasm. And also it could be a non-specific back pain, and it should be spondylolysis or spondylolisthesis, because that scoliosis alone causing back pain is not always common. There can be co-pathologies. So here we thought it could be the adolescent idiopathic scoliosis with the musculoligamental strains, which was tentatively diagnosed, and management was reassuring, because obviously we couldn't find any features of infection, neoplastic features or arthritis features. So we could be able to reassure the mother and child about this. We couldn't find any serious condition. At the same time, we didn't forget to educate the importance of follow-up, because there are some red flags. There's a chronic pain and there is a deformity, so it should be followed up. And we advised about the postural management and activity modification. And also for the pain relief, we prescribe NSAIDs, mainly the Brufen, and also we have arranged a full spine X-ray, AP and lateral, with the to review the patient after the X-ray. So this was the X-ray, the full spine X-ray. It shows there is a right convex lower thoracic curve. There was no other vertebral abnormality. This is a scoliosis with the 25-degree angle. So then the child was referred to the rheumatology clinic for the further management. So it was finally they have arranged bracing and physiotherapy. So around this case, I would like to talk few things about the evaluation of back pain in children and adolescents. So the last week we had a very good account on the back pain in elderly patient, 70-year-old patient. So this is another extreme age of the back pain. It's children and adolescent. Why we are going to talk about this more? Because that traditionally it has been viewed as a different, more serious than back pain in adults. High likelihood of having the serious underlying disorders. But it doesn't mean it's the majority of case, because benign back pain is the most common in this age group as well. So non-specific back pain and paraspinal muscle strains are the most common causes of back pain in children and adolescents. So while evaluating, it is very, very important to proceed the consultation. This is adolescent communication, because we should make sure extra care on that. We should give should make sure the privacy, confidentiality, and showing good empathy. And there may be sometimes we may need to communicate with the child alone. These should be included in the consultation, as is the adolescent patient. And another important, as I already mentioned, we will be approached with the heads assessment, home living and education, exercise and activities. There are drugs and sexuality, safety, suicide. These are the age risk factors, so risk assessment actually. So we are starting from the normal things, familiar things about home and education. Step by step, we are asking with deeper thing about the drugs and sexuality and suicidal things. So this also should be approach in this way for these patients. So then we are familiar with the assessment of the pain. Its site onset, character, radiation, associated factors, and time and severity. And there is a important should be given for the red flags. So while asking these few questions, we can safely, although we can exclude, we are a bit safe if we are asking these questions. Age itself is a red flag. Usually we know that while talking about back pain, we are telling that less than 20 years old is a red flag feature. So younger the child, the more likely there will be a significant pathology. So even if they're less than 4 years old, they are the most significant. There could be some pathologies. Could be malignancy and infection. These should be in our mind. In related to pain, the pain itself is a red flag by asking about severity. Very severe pain which interfere with the activity, constant pain, nighttime pain, progressive pain. This kind of pain are very significant red flags because we may think about inflammatory arthritis, spinal tumors, and tethered cord and syringomyelia or other non-spinal causes such as renal stone or sickle cell crisis also. And another important fact is the radiation. If it is radiated below the buttocks, we might think about the disc herniation or apophyseal ring fracture. And always we should ask about the trauma, acute or repeated trauma, because which may be the cause of spondylolysis or spondylolisthesis. And fever is the one of the important red flag. It may indicate spinal or paraspinal infection or extraspinal infection. As I already mentioned, they are all the referred pain. They should be having fever. And fever and weight loss and other systemic findings such as malaise or loss of appetite, they may indicate malignant tumors or inflammatory bowel disease related arthritis. And another important red flag is the morning stiffness. As usually lasting longer than 30 minutes. It may indicate inflammatory arthritis. And weakness, numbness, or bowel bladder dysfunction. The neurological symptoms, associated neurology, it may indicate that spinal abscess or transverse myelitis, spinal cord tumor, or nerve root compression. And features of referred pain, as already I mentioned those things. And next thing, the history of exposure to tuberculosis. It's a post disease. It is also one of the major cause for this back pain, and history of malignancy. So if there's malignancy, the possibility of spinal metastasis should be considered. So after the evaluation by asking the examination, history, then we'll have to proceed the examination. It include general examination, examination of the spine, and neurological examination. So spinal examination, the list also it's like exhausted list, but actually it will take few minutes to do. By some movement, we can do this examination and find a lot of information about the condition. So inspection, look, feel, move, and another provocative maneuvers. By looking, we have to look at anterior inspection. We can inspect for the posture and generalized patient's look. And another important inspection part is the lateral inspection. By looking at laterally, we can find out the thoracic hyposis or loss of lumbar lordosis, which may indicate discitis or spondylolisthesis, and hyperlordosis may indicate muscular low back pain. Posterior inspection, we have to look at any scars or muscle wasting, scoliosis, midline skin lesion, which indicate congenital spinal lesions, such as dimples, hemangioma, or hair patches. So these are some features of the asymmetry, many scoliosis. There we having head not centered over the body, one shoulder is higher than another one, and also one shoulder blade higher than other side, and hip also more prominent in opposite side. And also there is a gap between the arms and trunk. These are the simple observation we can spine as this the patient, my case. So then we have to move to the field. So palpation of the spine. So we have to palpate the spine and paraspinal region. Thoracic tenderness is often present in Schumann hypothesis. Sacral tenderness, lumbosacral tenderness may be present in spondylolisthesis or intervertebral disc herniation or lordotic low back pain. And also a prominent spinous process may palpable in the spondylolisthesis. And sacroiliac joint also, if there is tenderness, it may suggest sacroiliitis. Then we have to proceed with the range of motion. So we'll be assessed by asking the patient to touch their toes as much as possible and extend the spine and bend to right and left. So lumbar extension, the pain will be worsened by spondylolysis, and flexion, it will be worsened for the discogenic conditions. So this child at extension, flexion, we can just let her to do and observe. So some provocative maneuvers. The one of the very important test is the Adams forward bend test. Very simple test, takes few seconds by asking the patient to bend, stand and bends forward at waist. So assess the back for symmetry from the behind and the side. So if there is any rib hump, it may sign of scoliosis. The another test is the Faber's test. Actually, it's the simply figure of 4. We are making figure of 4 by hip joint. We are flexing, abducting, external rotating of the hip, and the force is applied on the knee and the opposite hip. So we are actually extending this sacroiliac joint. If there is any sacroiliitis, they will get pain, develop the tenderness, pain on this region. So it is indicate there could be sacroiliitis, but it should be make sure that the pain should be absent with the passive movement of the hip joint. So this is very important test, simple test to think about the sacroiliitis. The another test is the one leg hyperextension or stroke standing test. The child will be standing on one leg and lean backwards. The same side pain suggests spondylolysis, but it's low sensitivity and specificity because the negative test does not exclude the spondylolysis, while the positive test is common with other causes. But we can get some idea about whether it could be a spondylolysis. The another important test is the modified Schober test. Actually, this patient will be standing upright position. We have to identify the posterior superior iliac spine, which can be identified as dimple. So we have to make a line. Imaginary line is 5 centimeters below and 10 centimeters above. We have to draw and ask the patient to touch their toes to assess the lumbar flexion. Possible flexion, we have to ask the patient and measure the distance between two lines. So if the distance is less than 20, is abnormal. So it indicates reduced range of motion, which is associated with ankylosing spondylitis. The last test is the quadricep tightness, Thomas test. While asking the patient to, we have to flexor tightness, we can assess the hip flexor tightness. Patient, while in the supine position, examiner uses both hands to bring one knee to the chest. So if the contralateral leg lift over the table, it is positive. It indicates there is a flexor tightness. Like this image, this is negative, normal test. If the elevated lift the table leg, it is positive. So by doing these examinations, maneuvers, we can get some idea about the differential causes of the adolescent back pain. We can't forget about neurology. The neurology red flag features, by inspection, we can find that maybe atrophy, asymmetry, fasciculation, and pelvic tilt, which may be due to gluteus maximus of the same side weakness. Then, while assessing the power, the weakness related to pain or neuropathy, reflexes may indicate knee reflex L3, L4 root impingement, or ankle reflex may indicate S1 root impingement. And sensation, we can assess the dermatomal distributions to localize the nerve root involvement. And gait, heel and toe walking should be assessed. Refusal to walk may indicate discitis. Spasticity, ataxia, or instability, which may indicate spinal cord impingement or muscular dystrophy. And waddling gait or Trendelenburg gait suggests gluteus medius weakness. So this is a Trendelenburg sign. Usually while walking, it will be the same line. If there is weakness in the gluteus medius, the opposite hip will be dropped. This is a Trendelenburg sign. Then SLRT, as we all know, SLRT and slump test is the one of the modification of SLRT. We can identify root spinal root pains, impingement, and spondylolisthesis and other lesions. So SLRT, we are familiar with that. We will be raising the leg and the pain will be elicited during the throughout the that supply, nerve supply. The sensitivity can be increased by dorsiflexion of the foot. If we dorsiflex the foot, the pain sensitivity, that test sensitivity will increase, and also crossed SLRT test. It also increases specificity. If elevation of the contralateral leg also elicit the symptom in the other involved side, it is more specific positive for the sciatica pain. So the general examination, we are assessing for the vital signs, fever, tachycardia to exclude the systemic illness, lymph nodes. Lymph node may indicate infection or malignancy and inflammatory arthritis, chest to exclude the infections. Abdominal examination, look for any mass or any tenderness. Skin and nails, maybe for the skin lesion, rashes or nail changes, it may suggest psoriatic juvenile idiopathic arthritis. And maculocephaloid macules to suspect neurofibromatosis. And musculoskeletal system, we may just have a look about other joint and range of motions, which may indicate some generalized pathologies. So after the history and examination, that how to proceed with these patients. So if there is a normal findings with the patient with the intermittent or recent back pain, it could be most probably non-specific back pain. So we can prescribe home-based exercises or NSAIDs, and we may reassess the patient in 3 months' time. If improvement, we can discontinue the treatment. If no improvement, we may proceed with the basic investigation. But after the history and examination, if there is abnormal findings or red flag features, such as night pain or systemic neurological symptoms or activity limitation or pain more than 1 month, we may proceed with the basic investigation such as at least radiography and full blood count, CRP, and ESR. So according to the results, we can think about other differential diagnoses. So which are specifically mentioned here. If the otherwise healthy child or adolescent with the back pain less than 4 weeks, no warning signs. If we suspect specific cause, like our case, such as scoliosis, we may need to additional evaluation. But if there is no specific cause was found, and also there are a clear precipitating factor, generally we no need to do any laboratory investigation or imaging. There can be therapeutic trial of conservative measures. We can do brufen, acetaminophen for pain control, avoidance of pain triggers, physiotherapy to strengthen the lower back and improve posture. But we should always think about to review the patient. Children with no specific cause of back pain identified should be re-evaluated after 4 weeks. If the pain persists, it is reasonable to obtain radiograph. So after trial of treatment, if the pain not improved, we may need to think about other causes and may proceed with the imaging. So laboratory evaluation, it is not much we can do in the primary care. The full blood count, ESR, CRP. The 3 important investigation will give a lot of information about this other differentials. And depending on the other suspected causes, we can proceed with the investigation. Suspected infection, we may go for blood culture, UFR. Malignant suspected, we may go for like LDH and uric acid. And inflammatory arthritis, HLA-B27, we may to do, and urinary, other UFR and other liver function test. So this is the overall evaluation of the back pain in the patient with children and adolescent. But my case was the scoliosis, mainly the curvature of the lateral curvature of the spine. I would like to talk with more about the evaluation of the spinal curvature. Spinal curvature is not always the structural. As our colleagues mentioned earlier, the non-structural curvature also we should suspect. That mainly that pain from the infection, tumor, trauma, there will be curve due to muscle spasm or relieving pressure or nerve compression, which also can cause non-structural curvature. Structural curvature, it's if the angle of the curvature is less than 10 degree, it is normal limit. It is no, there is no long-term clinical significance. If more than 10% degree of the curvature, then only we will think about scoliosis. Actually, it's associated with the rotation of the spinal column. So, scoliosis, it can be idiopathic or non-idiopathic. Non-idiopathic, there will be secondary causes. If we exclude the secondary causes by asking history and examination, sometime investigation, we may think it's idiopathic. The idiopathic also can occur in the old age group, but the adolescence is the most common. So the overall idiopathic scoliosis, most common type of scoliosis, 80 to 80%, 85% is adolescent idiopathic scoliosis. So non-idiopathic scoliosis, what we'll be thinking? It could be, if there is a red flag features of the atypical curve, we might think it could be non-idiopathic. Mainly that if it is in male, if there's a night pain, because if the scoliosis can present with due to other secondary causes. So we also think about this night pain, left side thoracic curve, an abdominal neurological sign, rapidly progressive curves, or childhood onset. If there are these factors, these red flags are there, we should think about the secondary causes, non-idiopathic causes, because which can be caused by neuromuscular causes or congenital causes and other neurofibromatosis. There are multiple causes. So adolescent idiopathic scoliosis, the prevalence is 3%, but only 10% will require the treatment, or 0.3% of the population. Males and females are affected equally. However, there is risk of progression 10 times higher in females than males. This is a latest study from our country, which is done in 2023 in the 10 to 15 years students from government schools in Colombo. The prevalence was 4.7%, which is correlate with our regional. The worldwide 3%. Our prevalence is 4.7%. Another interesting thing, they have able to diagnose by using simple screening maneuvers, which I mentioned earlier. I will be discussing it later, and scoliometer reading. So the recommended conclusion, they recommended active screening, using the scoliosis screening maneuvers and scoliometer for prevention of this complication as an adult. So this is very important now. the general practice of family physician, is it very simply we can do this if we find an adolescent patient with the back pain or not with back pain, we can just think about this different in adolescent idiopathic, and we can do some screening maneuvers. So why it's important if untreated, if the scoliosis is untreated, deformity can progress. So finally, an adult age, they will end up with the back pain, the lumbar radiculopathy, cosmetic problems, nerve damage, and important, the cardiac and pulmonary restriction also can present. If it is the congenital one, it's more, they can, if it is severe, if curvature is more, and there will be a possibility of more complication, cardiac and pulmonary restriction. So there was awareness programs. Actually, this is the one where this is important topic. While we're doing orthopedic appointment, they have arranged, the Orthopedic Association arranged this awareness walk, which indicates the importance of the scoliosis screening and education. So they issued this handbook, which is very useful. We can download from online, and it's very basic. All the basic details, we can for the parents.
Why it's stuck? Oh, what happened?
Yes, ma'am. Sorry.
I think only few slides, isn't it?
Yes. So now the role of family physician. So as a first conduct here, we are going to, with the patient will be presenting us with the multiple that as already mentioned, that it may be observed by the parent or teachers or patient itself, and they present with some symptoms. So we have to look at the signs of scoliosis by inspection, as already mentioned. So that asymmetry and all the other features. Then we can do the Adams bending forward test, simple test to look for the any rib hump during the flexion. And as there is a leg-length discrepancy also can cause this curvature, we should measure the leg length discrepancy. So which is measured between anterior superior LA spine and medial malleolus. If more than 2 centimeters, it's abnormal. If less than normal. And another important assessment is scoliometer. It's like a masons are using to make that flat alignment. So same thing we are using here is scoliometer. So nowadays the smartphone also can be used. It's available, freely available. We can use smartphone too. So with the curvature, how much it's rotated. So we can identify the ATR, angle of trunk rotation. So after this assessment, if there is no evidence of scoliosis and scoliometer, if the angle is less than 7, we no need to do anything. Just to, if may need, we may follow after 6 months. If there is evidence of scoliosis, if there is that rotation is more than 7, we proceed with the radiograph. It should be standing full length, posterior view or lateral view of the spine. And after the X-ray, we are measuring the cob angle. This is the one going to depend on this cob angle. We are going to define the treatment modality. So it's also a bit technically may be difficult, but it is not much difficult for us to do, because we have to look at the apex of the curvature. This is the apex of the curvature. From that, we have to find more tilted vertebra above and below. So then we can draw a perpendicular line for the most tilted vertebra on the upper apex. So there is another perpendicular line for the lower apex. The angle is, while connecting these two lines, we can get the angle, but practically it will go beyond our X-ray, or it will go beyond the dark field. So we can't measure that. So we are drawing a right angle for both this, and this is the cob angle. So this is from the real X-ray, the most tilted vertebrae, upper vertebrae and lower vertebrae, and upper part we are drawing that perpendicular line, and here also. Then we are connecting with the right angles, and this is the, so this is a 56. This is a cob angle of this curvature. So after the cob angle, as I already mentioned, if there is 10%, 10 degree, we can exclude the scoliosis. If more than 10, it is the, we can diagnose scoliosis. So as a coordination of care, we have to refer the patient. If we are confident enough, if we exclude the scoliosis, if there is less curvature, we may think about follow-up. But usually that our people, we are referring the patients. Mainly if there is red flags, if the ART, that rotation is more than 7 in the scoliometer, and cob angle 20 and 20 to 24, or it's more than 25. If there's a progression, usually these patients should be referred to the orthopedic or rheumatology, depending on the curvature. So as a continuity of care, we have to think about, we should know about some basic about the management. Management wise, the management goal treatment is to avoid the progression more than 40 at the maturity. The thing is that that curvature, while child getting mature, progress, and the curvature also will progress. While the maturity is attained, then stop. So our aim is to keep it less than 40. So that management is individualized. So it depends on the curve magnitude by assessing the cob angle and growth potential. That if grow already somebody attained the skeletal maturity, we are not worrying about that. But younger child, we have to think it may progress. So, and other patient and caregiver preferences. So how to assess this remaining growth, whether this child will be getting more progress or not, we can assess by the same X-ray, which will include the pelvic region as well. So this is the retrograde ossification of this iliac apophysis, which is divided into 4, and if it is if the child getting growing, it will be completed. This is a grade 5. So if there is a lesser grade, it means there is a growth is remaining. So grade 1, so there is a growth. For example, this case it is a grade 2. It means there is a substantial growth remaining. If completed, then there is no growth at all after the completion. So treatment modalities, there is observation, bracing, and surgery, which adjunct to observation bracing, we are referring for the physical therapy. Observation is if less than 20 degree, it's requirement for the observation. And 20 to 40 is depend on the maturity we can observe. The patient should be observed clinically and radiographically. The frequency also, how frequently we have to repair, is depend on the radiographic severity of the scoliosis. So this is a bracing, which is from our country also. They have to wear this brace. Indication is the angle is 25 to 39. If immature children, 20 to 24, also we can recommend the bracing. If the cob angle more than 50, it is contraindicated. Cob angle less than 20 also, no need to for the bracing, it's observation. This is important patient instruction. The instruction, patient should wear this brace for 18 hours per day. But as much as possible, should be encouraged to wear at least 13 hours may be adequate, because the efficacy of bracing is directly related to the number of hours per day that brace is worn. And also, the many sports can be played while wearing the brace, but it may be removed for sports that cannot be done while wearing it. For example, swimming or gymnastics, but otherwise, the child can play with the brace. Surgical correction, if definitely indicated more than 50, but immature patient, 40 to 50, it should be think about that. This is the summary of the treatment. So less than 25 observation, but if very immature child, you may think of in the 20 degree. Bracing is 25 to 45, surgery more than 45. The follow-up, usually the orthopedic follow-up, they will depend on the severity of the curvature, they will follow up. But all the patients should receive regular primary care follow-up during adulthood for clinical monitoring, for asymmetry or curve fluctuation for quality of life. So there will be some surgical complication after if the patient is referred for the surgery, neurological, respiratory complication, cardiac complication, but these are very compared to the complication due to the curvature, severe curvature, these are least common complications. So usually the outcome for patient is generally favorable, whether observation, bracing or surgery. They have slight increased risk of back pain and degenerative disc changes compared with the patient without AS, but there is no increased risk of mortality or adverse pregnancy outcomes. So these are my references. So any questions on this?
Good evening, Dr. Imran.
Yes.
It's really nice, your presentation, and you mentioned everything briefly. I just wanted to know whether this scoliosis, whether there is any relationship with the heavy backpack, or did you find any risk factor in the patient's history, which we can attend?
There is no there is no direct risk factor. Actually, it's a growth related. If we exclude the congenital or other secondary causes, it's usually due to the related to growth. While the growing child, there is a possible curvature. I couldn't found other factors which will aggravate the thing, but I should actually I have to refer further on that.
Well, one more question. Hello, Dr. Imran. Yeah, I want to know because sometimes if it is congenital, I think this might be a late diagnosis. Did you explore the history to find out whether the patient had symptoms long back, or is there anything to do like to avoid this late diagnosis? As you said, we can screen through this mobile lab scoliometer. That's really good that you have mentioned it.
Yeah. Yeah, actually, this child, I didn't include this history because to make it bit differential bit tricky. So actually, she didn't have any features of that. It's a back pain also. It's a new onset back pain last 2 months. There's no past history of anything related to that. But at the same time, even the child and parent did notice this curvature. That is also one important point. So they missed that actually. And another thing is what the literature says, sometimes that adolescent, that age group, they find they don't tell to others about this. Sometimes they find mild curvature, they might tell to others about their problem. So it may be hidden. So according to as you asked this question, according to the history, I couldn't find any past history of scoliosis or congenital scoliosis related features.
Yes, the thing is actually we want to limit the things, in the data because we want to talk about not only the scoliosis at the beginning. So we want to get all the differentials. That's why, I want to make the history very short and you to talk about the differentials. So that's the main reason. Otherwise, all the things, if you could mention everything at the beginning, so everybody, it's very easy for anybody to give the diagnosis. It's for not only for the scoliosis, in a patient who comes just baby, comes with just back pain, how do you assess is the most important. For that only, otherwise he could have mentioned. Good that you talk about that, because this is the way, like anyway, it's I see the difference, like from the, like from your, the way you present everything, it's totally different. With a very slight sort of information, if I give something, so they nicely take everything nicely and they do a nice presentation. I'm very happy about that.
Thank you very much.
Yeah.
Yeah. Thank you very much, madam. So actually, I have to thank Lalanda madam. So she spent a lot of time to explain, and actually, my earlier presentation was in a different way. Madam is the one advised and corrected and to make this presentation. Thank you very much, madam. And I would like to thank for the college also to giving opportunity to this presentation, and for the other coordinators.
Thank you very much, Imran. So very comprehensive, that is how we expect from you all, right? So we see how competent you all are. So it's just not like the doctors who are working. So you are very capable people, right? So I'm very, very happy about you all. Thank you very much again.